Good morning, everyone. My name is Camilo Gonzalez Velasquez, co-host of the Thyroid by MD's webinar series. It is my immense pleasure to introduce the distinguished guest for today's session. First, we're gonna introduce Dr. Charit Taneja. Dr. Taneja is an endocrinologist and assistant professor of medicine at the Sugar School in Medicine of Hofstra, Northwell. Following his medical education in New Delhi, India, he completed his residency in internal medicine at Mount Sinai Beth Israel in New York, and further honed his expertise in a fellowship in endocrinology and metabolism at the University of Pittsburgh Medical Center. His clinical practice revolves around management of benign and malignant thyroid disorders, and his research pursuits focusing on clinical and molecular characteristics of low thyroid nodules and cancers. Next, I'm delighted to present a close and esteemed friend of Thyro, Dr. Margaret Brandwein-Weber. Dr. Brandwein-Weber currently holds the position of Chief of Pathology at Mount Sinai West and is the Director of the Head and Neck Pathology Fellowship. Her leadership in the field is advanced by her tenure as President of the North American Society of Head and Neck Pathology. Beyond her committee contributions, Dr. Brandwein-Weber has enriched the field of head and neck pathology with more than 130 published manuscripts and 50 book chapters. Furthermore, she actively participates as an investigator in NIH-funded research initiatives and never turns down an opportunity to enjoy a Friday morning teaching us about thyroid pathology. As much as I could go on speaking of our guests, I would like to hand the mic to Dr. Taneja, but before I do so, I would like to remind everybody in the audience to send in any questions they might have through the Q&A function, and we'll try to get to them before the end of the hour. So, Dr. Taneja, mic's all yours.
All right, I will share my screen. All right, excellent. So I'll get started. Thank you, Camilo, for that kind introduction, and thank you for the invitation today to present our research. I'll get started. I do not have any financial disclosures. And this is a study that I'm presenting today. So it's titled Clinicopathologic Characteristics and Post-Surgical Follow-up of Non-Invasive Follicular Thyroid Neoplasm with Papillary-Like Nuclear Features, or NIFTP, in the Postnomenclature Revision Era. This was published late last year in Thyroid, and the QR code is on the screen for everyone they need. So I'll go over the background of what NIFTP is, talk a little bit about our study, and hopefully open this up for discussion. And thank you, Dr. Brandwein, for being here. So firstly, what is NIFTP? So we know that about a fourth of papillary thyroid cancers are follicular variant PTCs, and the rest being conventional or classic PTCs. Follicular variant PTCs can further be divided into encapsulated follicular variant PTCs and infiltrated follicular variant PTCs on the basis of whether or not they have a capsule. The infiltrated follicular variant PTCs behave more like classic PTCs in that they harbor BRAF-like mutations, more likely to have lymph node metastases, more likely to have local disease and recurrence. The encapsulated follicular variant PTCs are mostly RAS-driven, and they can be further subdivided into the invasive encapsulated follicular variant PTC, characterized by vascular and capsular invasion, and then the non-invasive encapsulated follicular variant PTCs, which are these indolent RAS-driven lesions without any capsular or vascular invasion. And this is the group of lesions that was reclassified as NIFTP, or non-invasive follicular thyroid neoplasm with papillary-like nuclear features in 2016. So prior to 2016, thyroid tumors were basically classified into being benign or malignant. There was no room or scope for a pre-malignant or pre-invasive lesion, such as the carcinoma in situ seen in other cancers. And this changed in 2016 when the non-invasive encapsulated follicular variant PTC was reclassified to NIFTP. And this was done as a means to reduce overtreatment of thyroid neoplasia. They describe these lesions as RAS-driven lesions, which are indolent lesions typically treated with lobectomy and without the need for radioactive iodine. And this was based on their indolent behavior and really minuscule risk for recurrence after a section. So this was the initial paper from JAMA Oncology in 2016, reclassifying these lesions as NIFTP. And this caught a lot of press attention. We all know, we've all seen this New York Times clipping where thousands of people are going to be downgraded from having a cancer to now this new indolent lesion without the word cancer in its name. And on the right side, I've included the initial criteria that they developed in 2016 for diagnosis of NIFTP, which were revised in 2018, and I'll go over them a little bit in the next slide. So these are the criteria from the 2018 revision, this was published again in JAMA Oncology in 2018, and I've highlighted the ones in red that were changed from 2016. So for diagnosis of NIFTP, the primary criteria are encapsulation or clear demarcation from the remaining thyroid, presence of a well-defined capsule, a follicular growth pattern with no well-formed papillae, no psammoma bodies, less than 30% solid or trabecular or insular growth pattern, moderately developed nuclear features of PTC, so nuclear score 2, or even 3, but 3 requires a very close inspection of the entire tumor for any papillary structures, no vascular or capsular invasion, and no tumor necrosis or high mitotic activity. The 2018 revision also suggested secondary criteria, which are not required for the diagnosis of NIFTP, but definitely support the diagnosis. And these are the lack of BRAF V600E mutations, if available, and the lack of high-risk mutations such as TERT promoter mutation and TP53. So one of the criteria that was changed from 2016 to 2018 was that they changed it from less than 1% well-formed papillae to no well-formed papillae. And this was done really to avoid misdiagnosis of classic PTC as NIFTP, and classic PTC would be characterized by true or well-formed papillae. And I've included a picture on the right side. So I'm not a pathologist, but I like looking at papillae. And as you can see, true papillae are, very nice, well-defined fibrovascular cores lined by cells that have very classic nuclear features of PTC. So the presence of such papillary structures should really exclude the diagnosis of NIFTP. Now, the most recent WHO classification of endocrine organs recommends using the less than 1% papillae criteria. So this is a small area of debate, and different institutions use different criteria in this respect. So after nomenclature revision in 2016, what all happened? So in 2017, NIFTP was included as in the WHO classifications of tumors of endocrine organs, and it still continues to be included in the most recent classification. In 2017, NIFTP was endorsed by the ATA Thyroid Nodules and Differentiated Thyroid Cancer Task Force. And they suggested that NIFTP management should be similar to low-risk thyroid cancer, given the lack of guidelines around these lesions at that time, meaning that lobectomy would be sufficient. There is no need for remnant ablation, keeping the TSH in the lower half of the normal range, similar to low-risk thyroid cancers. And in terms of surveillance, the task force suggested occasional thyroglobulins and ultrasounds, but they said that the intensity and duration of follow-up is really to be determined when longer-term studies are available about these lesions. Lastly, as of January 2021, NIFTP is no longer reportable as a cancer in the NCI-SEER database. So talking a little bit about the existing studies prior to our studies. So on the right side, you'll see this table from a very nice meta-analysis done by Turan and colleagues. And they included 1,242 cases of NIFTP, either retrospectively classified from encapsulated follicular variant PTC or diagnosed as NIFTP. And they saw really a very minor risk of lymph node metastases or distant metastases, 1.8% or 0.08%. Now, if you see, excuse me, some of the initial studies after the reclassification did have a 4 to 6% chance of lymph node metastases. And some of these lesions were later found to have BRAF V600E mutations or minor papillary structures, which led to us thinking that maybe these were the invasive forms of the encapsulated follicular variant PTCs and should not have been classified as NIFTP. And then some of these studies were what led to the revision of criteria in 2018 to say that no well-formed papillae should be included as NIFTP. So one of the things about these studies was that the primary inclusion in these studies were cases that were retrospectively diagnosed from reclassification of encapsulated follicular variant PTCs. So a lot of these patients were initially diagnosed as the follicular variant PTC, and they received cancer-directed management. So many patients underwent total thyroidectomy, and not uncommonly radioactive iodine also after. The novelty of our database was that we only included patients after 2016, So these were patients whose primary diagnosis was NIFTP at the time of resection, and any management that was done after resection was with the NIFTP diagnosis in mind, and they did not receive any cancer-directed management. So starting with our study, the main aim of our study was to assess the recurrence rate in a consecutive cohort of patients diagnosed with NIFTP at the time of resection and managed under a prospective clinical algorithm. Our secondary aims were to look at the sonographic, clinicopathologic, FNA, and molecular features of thyroid nodules that were diagnosed as NIFTP at the time of resection. So the study was conducted at the University of Pittsburgh Medical Center, and I'm just sharing here our institutional protocol for surveillance of NIFTP. So even though NIFTP is an indolent lesion sufficiently treated with lobectomy and without radioactive iodine, there is really a lack of studies looking at whether there should be any surveillance for these lesions after resection or not. And as a result, there are no current guidelines about how these lesions should be managed afterwards. As I mentioned before, the ATA task force suggests that these should be managed by similar to low-risk differentiated thyroid cancers with occasional thyroglobulin and neck ultrasound monitoring in the post-resection time. In practice, it's very variable. Some people are taking it very literally and not surveying NIFTP patients at all after surgery, and some patients are being surveilled similar to low-risk thyroid cancers. So on this slide, you can see our protocol, and it's very similar to what the ATA task force suggested. So after surgery, keeping the TSH in the lower half of the range, getting ultrasounds and thyroglobulins for at least 5 years before they can potentially be discharged to their primary care doctor if there is no recurrence. So this was a retrospective single institution study done at the University of Pittsburgh Medical Center. We identified cases using our EMR over a period of 5 years, from 2016 to 2021. We included patients who were diagnosed as NIFTP on surgical pathology. We did include patients who had coexisting papillary or follicular microcarcinomas without any angiolymphatic invasion or extrathyroidal extension at the time of resection, because these incidental lesions are known to carry an excellent prognosis, and we would think that no additional treatment would have been warranted other than resection of the NIFTP for these coexisting lesions. We excluded patients who had been retrospectively classified. So patients who initially had a cancer diagnosis were not included in this study. Patients with coexisting papillary or follicular carcinomas more than 1 centimeter, or those who had angiolymphatic invasion or extrathyroidal extension at the time of resection were not included. And any coexisting medullary or anaplastic thyroid carcinomas were also excluded. So the NIFTP diagnosis was based on the revised criteria from 2018 that I shared before. The slides were reviewed by designated thyroid pathologists. The entire capsule and entire tumor was examined. We defined recurrence as evidence of structural disease on neck exam or on imaging, or evidence of elevated thyroglobulin after a total thyroidectomy. We did not use thyroglobulin levels after a lobectomy in consideration of assessment of recurrence, given that these are not very validated for this population. So as you can see here, after using our inclusion and exclusion criteria, we came down to about 79 patients with 84 NIFTP lesions. So this is over 5 years from a large academic institution with a large population of thyroid cancer. So we can estimate from this that the prevalence overall of NIFTP diagnoses is still pretty low, 79 patients over 5 years. The mean age in our cohort was 51 years, and the majority of the cohort was female, about 83%. So talking about the ultrasound characteristics of these nodules, the mean nodule size was 2.8 centimeter, but we had nodules up to 8.2 centimeter in size. Most of these nodules were solid isoechoic or hypoechoic with a smooth margin, 92% falling into TI-RADS 3 or 4, which is mildly or moderately suspicious. The smooth margin seen on ultrasound really corresponds well with the intact capsule that is seen in NIFTP. We rarely had patients in the TI-RADS 5 or highly suspicious category because, by virtue of these lesions being encapsulated and non-papillary, we would not expect to find high-risk features such as irregular margins, extrathyroidal extension, or microcalcifications that are seen more in the papillary type tumors. And these findings correlated with previous studies as well. Talking about FNA, so most of our nodules fell into the Bethesda 3 or AUS and Bethesda 4 or follicular neoplasm categories. Only one of our nodules was suspicious for malignancy or Bethesda 5, and this is a little bit different from previous studies. Our rate of Bethesda 5 was very lower. Our hypothesis is that the previous studies did include some lesions with minimal papillary structures, and we did not. So presence of minimal papillary structures would correspond to having more pronounced nuclear features of PTC, which could potentially result in a Bethesda 5 diagnosis with cytology. So based on our findings, we suggest that most NIFTPs are Bethesda 3 or 4, while conventional PTC would be Bethesda 5 or 6. However, we cannot differentiate NIFTP from the invasive follicular variant PTC or follicular thyroid carcinoma on cytology, as they share similar features. The vascular and capsular invasion can really only be seen on surgical resection. In terms of the molecular testing, a large part of our population had molecular testing done on these nodules, and 93% of them had positive tests on molecular testing. Going in line with the diagnostic criteria, none of our lesions had BRAF V600E or any high-risk mutations. The most common mutation that we saw in our cohort was RAS mutations, either alone or in combination with other lower intermediate risk mutations, and this made up 75% of the patients. This was followed by IGF-2 BP3 TATA fusion, which is another low to intermediate risk type of genetic alteration, and then the K601E mutation of BRAF, which is another RAS-like mutation. In terms of surgical outcomes, about 2/3 of our patients underwent a lobectomy, and none of them had a completion thyroidectomy. None of the patients in our cohort received radioactive iodine. We had about 20% patients who were large NIFTPs or more than 4 centimeters in size. We had 5 patients with multifocal NIFTP, one of whom was bilateral. And about 1/4 of our cohort had the coexisting papillary or follicular microcarcinomas without extrathyroidal extension or angiolymphatic invasion. Talking about surveillance, so our mean follow-up was 28.5 months, so about 2.5 years. But many of our patients had longer follow-up, some of them being followed for up to 5.5 years. All patients had at least one office visit and one neck exam during the follow-up period. And about 80% of our patients had either the thyroglobulin levels checked or a neck ultrasound or both. We did have about a 20% loss to follow-up. In terms of our primary outcome, none of the patients with the available data for follow-up had any evidence of structural or biochemical recurrence at the end of our follow-up period. So in essence, in our cohort of patients diagnosed with NIFTP at the time of surgical resection, and then algorithmically managed with this institutional protocol based on the NIFTP diagnosis, there was no evidence of recurrence over 2.5 years of mean follow-up. This was the first study of its kind that included patients only after 2016. There's one more study now from Boston that was actually discussed at this conference a few weeks ago, with similar outcomes. We had 16 patients with large NIFTPs, the largest being about 8 centimeters, and we had 5 patients with multifocal NIFTP and 1 bilateral, again without any evidence of recurrence. So our rates of multifocality and bilaterality of NIFTPs were lower compared to the previous studies, and we think it might be possible because of the higher rates of lobectomy in our cohort, so the other side not being examined. About 1/4 of our patients had the coexisting papillary or follicular microcarcinomas without any high-risk features, and this was again not associated with any recurrence at follow-up. So, we felt that this did not add any higher risk to these NIFTP lesions. Our study did have several limitations. The first and the main one being that this was a retrospective study. We had an institutional protocol, but this was done retrospectively. The institutional protocol was suggested. So even though we had about 80% of patients who were surveyed using neck ultrasounds or thyroglobulin, our loss to follow-up rate was about 20%. We had a relatively short follow-up just on the basis of the fact that NIFTP is a new lesion. Our follow-up was about 2.5 years. And we know that thyroid cancer recurrences can occur with a long latency, up to 5 to 10 years later. So longer term studies are really needed to better understand this surveillance. And lastly, and another important one, this study was conducted at a large academic center with a thyroid center, dedicated thyroid pathologists, endocrinologists, surgeons. Some of the pathologists that were involved were actually involved in the initial reclassification of NIFTP. So we feel that the pathologists had that in mind with using stringent criteria for NIFTP diagnosis, using the criteria regarding the well-formed papillae very stringently. So we feel that it's possible that our study did not have any metastases or recurrence because those criteria were followed very strictly. And it's hard to say how generalizable this might be in all clinical settings or community settings where NIFTPs might be diagnosed. In terms of what's happening now and a little bit in the future, we need studies with longer term follow-up to better understand the need for surveillance and the intensity of surveillance for these patients diagnosed as NIFTP. We need more studies on lesions such as large NIFTPs, bilateral multifocal NIFTPs, oncocytic NIFTPs. So all of these lesions are very small numbers in the current studies, and it would be beneficial to have these studies to understand their disease course. So I would like to highlight 2 studies before I end. One of them is by Vignali et al., and this is published the same year as our study. They did not look at recurrence, but they looked at a large population of NIFTP patients, and they found that around 44% of their NIFTP patients had a coexisting tumor. So it was not a solitary lesion. They had either multifocal NIFTP or an additional papillary or follicular carcinoma in addition to the NIFTP. And that just goes to say that maybe there is a role for some kind of surveillance for these lesions because they often have coexisting tumors with them. It's just hard to say how intense that follow-up and surveillance needs to be. And the second study is from Boston, and this was a study which was a very similar study designed to ours. They had a larger cohort than ours. They found similar clinical characteristics, similarly found no recurrence at their mean follow-up of around 3 years, so similar follow-up to ours. And most of their patients also had lobectomy and no radioactive iodine, so very similar. So in the end, I would like to say that we need more studies similar to this second study and to our study, looking at NIFTP outcomes in the long term. And NIFTP is really, in its infancy or toddlerhood, given that it's only been a few years, and it's just by the virtue of that, it is hard to have long-term studies right now. But going forward, it would be beneficial to have more of such studies so that institutions such as the ATA and others can formulate more, formal guidelines as to how these lesions need to be surveilled. And that is the end of my talk. I would like to thank all of my co-authors, and especially Dr. Yuri Nikiforov, who has been an excellent mentor and advisor to me over the last few years. Thank you.
Thank you, Dr. Taneja. That was an incredible lecture. I'm just gonna jump over with Dr. Brandwein-Weber, and we'll come back to the questions. There's a couple from the audience already, so we'll come to those at the end of the hour.
Good morning, everybody. Do you hear me?
Yes, perfectly.
And you see my screen? Thank you very much, Camilla, for that very generous introduction. And the operational word here is enjoy. You said that I never fail to accept an invitation because I enjoy these so much, and I really do. I can't stop plugging these Friday morning sessions for my residents and for other head and neck pathologists that I meet, because really it's a very high quality, consistent educational program. And I know that I've benefited so much just listening to this and presenting in this program religiously. So I'm not clever enough to have any financial disclosures.
Dr. Brandwein, I'm sorry to interrupt you. I cannot see your screen. I don't know if Dr. Nate.
I was just saying how I was not clever enough to have financial disclosures. Okay, so congratulations to Dr. Taneja for this really very much needed prospective, diagnostically prospective study with clinical follow-up. And so why is it important to accumulate more of these types of studies? of prospectively diagnosed NIFTP as compared to the retrospective reclassification studies? Well, firstly, you want to, if as we are saying, since this is a really indolent neoplasm that doesn't require cancer treatment, well, we want to have we want to amass experience with patients who have had therapeutic homogeneity. That means that you want to exclude patients who were reclassified from encapsulated follicular variant PTC, reclassified as NIFTP, but were treated with total thyroidectomy because they were thought to have cancer, and importantly, were treated with radioactive iodine. So what we're saying is, if this is your only lesion and it's NIFTP, lobectomy is enough. Radioactive iodine is not necessary. And of course, we want to assure diagnostic homogeneity. I don't know why I chose those words before my second cup of coffee. Diagnostic homogeneity. So we want to ensure that these tumors are treated in the same way grossly. The entire capsule needs to be submitted and analyzed, and the entire tumor really needs to be submitted and analyzed, and in a stepwise fashion. And of course, we want to ensure that there's a uniform adherence to exclusionary criteria. My goodness, hold on, sorry. Yes. Just a moment, please. Oh, rats. Okay, terrific. So let's talk about the diagnostic criteria. This is from an article by Raja and colleagues, and this was in Modern Pathology, and I have used a number of their illustrations, which I want to acknowledge because they're very beautiful. And so the first diagnostic criteria is that NIFTP has a discrete interface. It might not have a capsule, but at the interface, there's a real sharp division between the tumor and the surrounding thyroid tissue. If you look here on your left, this is not really like a basketball type of lesion, which makes our lives easier, but this is what I would refer to as like a slightly deflated basketball. And you could see there's a kind of wavy interface here. And when you see that wavy interface, you just ride the waves, you go through the whole thing, and you make sure that you don't see any capsular invasion. This is, my apologies. This is a very useful diagram, and this was published in the original 2016. This was in the supplemental materials, and then in the Modern Pathology article, there was a variation of this. But the nuclei, of course, are the nuclei of PTC. And it's been noted that the nuclei of follicular variant of NIFTP are not quite as well developed as what you would see in a classic variant of PTC. You look at a classic variant of PTC, you just glance at it and you say, I know what this is. Well, that's a little bit problematic because then you stop looking at the fine details that help you get to the diagnosis. So how do you make a reproducible diagnosis of NIFTP? So they published this diagram, and what we're doing is we're looking at 3 categories for nuclear features: the size and shape, the membranous irregularities, and the chromatin characteristics. To the left, you see the absence of these features of NIFTP, and to the right, you see that the features are present or sufficient. And you give a score of 1 point for sufficient or present features. So for instance, the nuclei, they may be large and elongated, but perhaps they don't have that much nuclear clearing. Well, if you get a score of at least 2 out of 3, then that's enough and sufficient to call something NIFTP. The way the nuclei are distributed, it may be patchy. There's no minimum criteria for the diagnosis of NIFTP, but Zubair has a reasonable rule of about 30%. When you look at established NIFTPs, it's not a criteria, but this is what we see. In established NIFTP, it seems to be that about 1/3 of the nuclei have these features. The follicular characteristics may be either microfollicular or macrofollicular. And actually, as we saw last week, it's the macrofollicular variants of these tumors that can be missed or misdiagnosed as benign. And here are the important exclusionary criteria that we heard very nicely from Dr. Taneja. Now, capsular vascular invasion is so obvious, it almost missed this list, but it's obviously, this is going to be non-invasive. Any well-formed papillae, and as we heard, the original criteria included isolated papillae, and we're going to see some data as to why that is, why there's now a change, okay? Any psammoma bodies, and of course, psammoma bodies are like the corpses of former papillae. Any tumor necrosis is exclusionary diagnosis, is exclusionary criteria, of course, and as we've heard many times, basically any tumor necrosis upgrades something to a poorly differentiated thyroid cancer. Same with mitotic activity. If you have mitoses in more than 3 out of 10 consecutive high-power fields away from an FNA site, that's criteria for poorly diff, and that's a completely different classification. And while we don't routinely look for molecular changes in these lesions, if we happen to have that data from an FNA, any unexpected high-risk mutations such as the BRAF V600, TERT, RET, or ALK mutations are exclusionary diagnosis. And multifocal tumors still can be diagnosed as NIFTP. There's no reason not to. And size, as I'll show you, has no exclusionary features for NIFTP. So let's talk about well-developed papillae. This is also from Raja's article. And so I guess you guys don't see my arrow, but what we see here is a papillae where in the center, there's no follicles. There are some vessels here. And so this is what's called fibrovascular core, a well-developed papillae. In contrast, if you look in the right, this is an evidence of hyperplasia. This was called Sanderson's polysters, or little pillows. So the papillae that sticks into a follicle itself is filled with follicles, not a fibrovascular core. So that's a pseudopapillae. So I'm going to show you some articles which are basically the basis for excluding any papillae in the diagnosis of NIFTP, sorry. And so the first one is authored by Cho and colleagues, where they look at the molecular correlates and the rate of lymph node metastases for NIFTP. And here there are 105 patients that have the criteria for NIFTP, but these were looked at from 2 different diagnostic criteria. When you allowed 1% of papillae in the diagnosis, that was 105, then 3% of these patients had lymph node metastases and 10% had BRAF. Now, let me just make this statement overall, that when there are lymph node metastases, they are really low risk lymph node metastases. And so they're not aggressive. They're usually, level 6, paratracheal, and not the type of lymph node metastases overall that would even predict recurrence. But be that as it may, there was 3% of lymph node metastasis in this group. When they made the criteria more rigid, so no papillae at all, that also sifted out any cases that had lymph node metastasis or BRAF. In this publication, they also presented a patient who had, that patient himself presented with bone metastasis. And then on retrospect, when they did the thyroidectomy, they found a single encapsulated follicular variant PTC with a BRAF mutation. Now, this would not have been called PTC, this would not have been called NIFTP to begin with, because there were a lot of papillae, but it was encapsulated and seemingly non-invasive. So it sounds like a scary scenario, but remember that this is a patient who presented with the bone metastasis already. And we've seen that. That's not, that's, in a case like that, there is no risk that that patient would have been called NIFTP from the onset. We've seen this data before. Ronnie has presented this in this venue, but it's relevant to present here again. And here they look at, well, how many papillae does it take to actually see some bad outcome in an encapsulated follicular variant PTC? And so here we have 235 patients who have these encapsulated PTCs with all different ranges of papillae. So from one end of the spectrum, these would the ones that would have limited or no papillae would be called NIFTP. From the other side of the spectrum, the ones that have a lot of papillae, well, they just be called encapsulated PTCs. And as you can see here is highlighted with the red. In the patients, so compare here these two columns of patients who do not have metastases or N0 versus those who have positive lymph nodes. The cutoff point for any positive lymph nodes seems to be less than 1% or more papillae, whereas in the patients who have 50% or more papillae in these encapsulated lesions, the majority of these, the majority of the patients with positive lymph nodes came from this subset. And now let's look at the BRAF mutations. So again, the BRAF mutations were very rare in the patient, or were uncommon in the patients who are negative lymph nodes or NX, versus quite common in the patients who had positive lymph nodes. So here are some further publications that kind of round out our experience with NIFTP. So the original NIFTP article in 2016 did exclude sub-centimeter lesions. And so in a follow-up publication in 2018 by Binju and colleagues at Memorial, they looked at 52 patients with sub-centimeter NIFTP, and this was a multi-center study. Patients had to have had at least 1 year of follow-up and no radioactive iodine. And so there is no reason to think that these patients should be excluded from the diagnosis of NIFTP, but here's the data that supports it. So these patients, 23 of these patients had lobectomy alone. The remainder had total thyroidectomy, and there was no recurrence seen in any of these patients. In 25 patients where there was 5 or more years of follow-up, the median follow-up was almost 10 years, and that's a really healthy follow-up, and no recurrence seen, as we would expect, but here's the data to support it. Another group of tumors that was excluded from the original 2016 publication were tumors that had oncocytic nuclei. So these are oncocytic NIFTP. And again, to address this gap, 61 patients were published from a multi-center study. Again, at least 1 year of follow-up, no radioactive iodine. The mean size of these tumors was 2.5 centimeters, and the less stringent cutoff of less than 1% papillae was included. The definition was that at least 75% of the tumor had to have abundant eosinophilic pink granular cytoplasm, and the nuclei had to be nuclei of PTC, not nuclei of Hürthle cell or oncocytic lesions. The majority of these tumors had RAS mutations, as we would expect. One had a weak BRAF driver mutation, which we also saw in Dr. Taneja's study, which is BRAF K601E. And as would be expected, the majority of these tumors had non-silent mitochondrial DNA mutations because they are oncocytic neoplasm. And again, there was no evidence of local recurrence, lymph node metastasis, or distant metastasis. 33 of this group of 61 patients, 33 of them had follow-up for 5 years or more, a median follow-up again, which is very healthy, of 10.2 years. Now, this is a study which I think is very important, because the larger the lesion, the more sections that you have to examine, one could say the greater the insecurity is of the overall finding, the greater the insecurity that you might miss exclusionary criteria. So what about large NIFTP? And as we heard, there were some tumors of over 4 centimeters also included in Dr. Taneja's study. Here we have a study of 79 patients, 4 centers, unifocal tumors, 4 centimeters or more, and the size ranged up to 8 centimeters. Now, I always say that 4 centimeters minimum is the size of worry. So as we know in general, the larger a tumor, and so 4 centimeters is that cutoff, and maybe even 3, the more likelihood that this isn't even going to be NIFTP, that you're going to find invasion. Alrighty, so 26 patients, or about a third of them, were treated with lobectomy alone. The remainder had a total, and little less than half had no radioactive iodine. So remember, this is again a retrospective study. These were called other things and then reclassified as oncocytic NIFTP. So larger tumors were more likely to have received radioactive iodine. And again, there was no recurrence, no untoward events in this entire cohort. 25 of these patients had follow-up of more than 4 years, no radioactive iodine, with a healthy follow-up of 11.2 years. One last word, and I found the study yesterday and I thought, well, it's a simple study, but it's nice to see. So just as I said, the larger the tumor, the greater the worry. The thicker the capsule, the greater the worry that there may be some capsular invasion. And this is something that's been known to pathologists forever. And so in this study, Dr. French and colleagues asked the question, well, what is the difference in capsule thickness with NIFTP and other tumors? And here we're seeing on the left an encapsulated lesion, and this would be considered a very thick capsule. And all the way in the bottom left, because of this thick capsule and because of findings that suggested invasion, they did deeper sections, which we all do, constantly, and they were able to document some invasion. So this would not be a NIFTP. But, this is a good question to ask. What is the difference in capsule thickness? So if you look at this bar graph, the smallest bar in blue, those are NIFTP, and the next bar in yellow, those are non-invasive encapsulated follicular variant PTC. So forget about the gray for the moment. So the yellow bar are tumors that we would not call NIFTP because they have exclusionary criteria, and their capsule is thicker than the usual capsule of NIFTP. And so that's something that is not surprising, and we see in practice, but here we see the numbers to justify it. So in general, it's the concept of NIFTP has changed the world for pathologists and for patients. It's very interesting that before NIFTP, there wasn't a concept of in situ or pre-malignant thyroid disease, unlike the breast, for instance, unlike the head and neck. And why is that? Because when you have a lesion, you're taking out the whole lobe, you're taking out the whole lesion, you've left the milieu that would develop the natural course of it. So it's taken this long for us to come up with a concept of pre-malignant or pre-invasive thyroid lesions. But I think that we can all feel very safe going forward that this is an indolent disease, as long as it's managed well from the pathology point of view, diagnosed well, and people are aware of the caveats and exclusionary criteria. I think that clinicians can feel very safe in treating these as a minimal risk disease. Thank you very much.
Thank you, Dr. Brandwein, for an incredible lecture as well. I'm going to say that I've learned more from pathology and NIFTP in this past 20 minutes than I did in the past 3 years. So thank you for that.
Hard to believe.
I'm going to start off the Q&A by doing a diagnosis kind of question first. Dr. Pinner-Smith is asking, why do we make a comment away from the FNA side when we are speaking about mitotic figures in the diagnosis of NIFTP? So
sure, it's very simple because an FNA is going to cause reactive changes, and part of those reactive changes are increased mitoses.
Perfect. Going forward, I'm going to start us off by going to the size question. So Dr. Brandwein was speaking about the size just a minute ago. In Dr. Taneja's publication, we also spoke about the 4 centimeter cutoff, and there's one question from Dr. Maya Shalom. She says, patients with tumors over 4 centimeters underwent total thyroidectomy. Do you think that maybe in cases that you suspect of NIFTP by sonography and cytology, and potentially by molecular testing, especially if they have RAS mutations, do you think that hemithyroidectomy for lesions over 4 centimeters would be compatible?
Shall I start with that? Well, I think that's what we're going for. you know. Now the whole thing is to make sure that, okay, if they were adequate, if hemithyroidectomy was adequate because there were no lesions on the other side, the whole goal of these prospective studies is to demonstrate that, yes, even with a 5 centimeter, lesion where you have a diagnosis of NIFTP, you could, a pre-op diagnosis, you can always do the hemi and wait for the final pathology. And then the final pathology will confirm whether or not the hemi was appropriate or is a completion necessary.
I agree with Dr. Brandwein. So, some of our patients with larger tumors had lobectomies, and if there's an FNA pre-op that is AUS with RAS-like mutations, and there's some sort of suspicion for this being NIFTP, there's minimal high-risk ultrasound features, I think a lobectomy is completely reasonable. With the patient being informed that just in case it's something else, we might recommend a completion later, but there's a chance that you'll avoid losing your entire thyroid.
And this comment takes me to my next question. Dr. Mike Villa, he congratulates you both for excellent presentations, and he's asking if pathologists had access to genetic testing of specimens prior to rendering the diagnosis.
Okay. So we always look to see what's available, because we always look to see what's available, but it's not a requisite. And the bottom line is the histology wins. Even when now, except in the scenario, if you have a BRAF, if you have a known BRAF mutation, and the lesion that it's coming from is what you're thinking is NIFTP, in that scenario, which I've not seen but makes sense, in that scenario, you step back and you say, I can't make a diagnosis of NIFTP here. Something is amiss. So when the data is available, we look for it.
All right. Well, thank you, Dr. Villa. It's so good to hear from you. So in our study, this was a retrospective study. So as Dr. Brandwein said, some of the patients had molecular testing available, and the pathologists were not blinded to that. So they did have access to that. How much it influenced their decisions about calling something, it's hard to say. We would like to believe that they followed the strict criteria, and it was based on the diagnostic criteria that these lesions were diagnosed as NIFTP, but they did have access to the molecular data beforehand.
So while I was listening to your lecture, I was also looking at the tables you presented to us, and I was scratching my head a little bit, saying, okay, so we have a patient that has an AUS plus result of an FNA. Potentially, you do have molecular testing. Do you have a sense of what were the drivers for patients getting either a total or a less than total thyroidectomy?
So in our population, major reasons for these patients getting total thyroidectomies were either patient preference or a coexisting diagnosis of a second thyroid nodule on the contralateral side, or coexisting Graves' disease, which led them to end up having a total thyroidectomy. It wasn't based on the molecular drivers as much, because as I showed in that table, none of the molecular drivers were really high-risk mutations. Some of them were low to intermediate risk mutations, such as RAS in combination with others, but really no high-risk mutations that would offhand tell you that, okay, this unifocal nodule needs to have a total thyroidectomy. So the decision for total was not based on the molecular data mostly.
Beautiful. So my next question would be, let's speak a little bit about the multifocality question. So how much do you feel that this changes the way we think about NIFTP? I take it from my experience, multifocal NIFTP is not a common finding in pathology. But what are your thoughts about and we always say like thyroid nodules harbor a different or a unique or a distinct risk of malignancy, if we could say that. So if you do have multifocality, does that change in any way your decision pre-op?
So I think in terms of multifocality, it depends on the laterality as well. So if it's a bilateral, there's bilateral thyroid nodules, and there's risk in both nodules of something being similar to NIFTP or encapsulated PTC, we would, recommend a total thyroidectomy. But let's say there's multifocality, meaning 2 nodules on the same side. Those patients could still get away with lobectomy. And, as we saw, at least in our cohort, there was not a recurrence seen. Our study did have a much lower risk, lower percentage of patients with multifocality, which, I think it's possible because of the higher rates of lobectomy in our population, that the other lobe was not examined. So these micro NIFTPs, or, tiny, less than 1 centimeter NIFTPs on the other lobe might have been there, but we don't know because they only got a lobectomy. And that raises the question of surveillance then, because if there is a chance of multifocality, especially in one of the recent studies from 2022 by Vignali, the one that showed that almost 44% of NIFTPs had an additional lesion that probably needed surgical management. I think there's a need for more prospective studies, especially addressing the concepts of larger NIFTPs and multifocal NIFTPs.
Thank you for that. So my next question is going to go for the hot word of the hour, the papillae question. So we're speaking about the papillae, the pseudopapillae, that percentage of papillae. So we're gonna, and I'm guessing that when we make the call of following up a patient with the pathologic diagnosis of NIFTP, you have to trust your pathologist. You have to speak to your pathologist, and there has to be a certain amount of trust. I'm going to go back to that. When this summer, when we were at the World Congress of Thyroid Cancer, I had the opportunity to speak about disparities and global differences in treatment of thyroid cancer. And those who know me would know that this was coming. I was speaking that treating thyroid cancer or any thyroid nodule lesion is like riding the subway pretty much, in a sense that everybody knows how the New York City subway works. It's pretty much a grid. It's pretty straightforward. You know where to get in, where to get off. And when you go into the subway, you always hear that warning, please beware of the gap between the platform. Mind the gap, exactly. Mind the gap between the platform and the train. And I was saying, when you ride the subway here in Mexico, the gap is bigger. We have a little bit of pushback from adopting new guidelines, new recommendations, new changes in recommendations, as in the percentage of papillae, etc. So as we all know, the biggest, or the chunk of patients that are treated in the community. So what do you think, what should we do when we get a diagnosis of NIFTP? Should we go back to the pathologist, ask them to look back if what percentage of papillae are found? What is your take-home message for people finding a NIFTP diagnosis? Do we surveil them? Do we say they're benign? How would you go about that in the sense of treatment outside of what I call ivory tower treatment? I mean, having Dr. Nikiforov by your side, having molecular diagnosis readily available, that does change the amount of trust you have in a diagnosis.
So I'll start. So one of the ideas about going from less than 1% to 0 papillae. So I showed you the data about what can be associated with 1% or so of papillae. It's a cleaner break. You know, the human eye can't really say, is it 0.5% of papillae or 2% of papillae? I mean, that is now, luckily, we don't really have to deal with that question often, but that is something that, we all acknowledge is it's an arbitrary cutoff and is really not something that we can do. It's really more relevant in the cutoffs, for instance, of tall cell. Can we really say, is something 9% tall cell, or might it be 12% tall cell? And that changes something. So again, when you make the diagnostic criteria cleaner, meaning no, you're going to have hopefully more homogeneity in the diagnosis. So if you're outside an ivy tower situation, I mean, there's no reason not to talk to your pathologist at any rate,
Right.
and just find out what school are they going by that, If they're going by no papillae, well, I guess that's more comforting, you know, because I would say that there is, you know, that's a limitation to expect somebody to make that kind of distinction by eye of less than 1% or more than 1%.
Yep, I couldn't say it better than Dr. Brandwein. So I think the less than 1% papillae criteria, you know, may be suitable for, you know, a larger academic institution with a larger volume of NIFTP, where people are diagnosing these more commonly. And you know, they understand the difference between the true papillae and the pseudopapillae that Dr. Brandwein showed pictures of, and you know, knowing that those pseudopapillae can still be included when we're diagnosing NIFTP, but really a true papilla should not be included. When translating this to the community, I think maybe the no papillae or 0% papillae makes more sense, and that would, you know, establish more diagnostic homogeneity, and you know, in that sense, you know, trust in your pathologist would be higher if someone is saying that there were no papillae at all.
Could you hone in just a second on your institution's protocol for following up patients with NIFTP?
So our institution's protocol was similar to, you know, low-risk differentiated thyroid cancer management, as was suggested by the ATA task force in 2017 after the nomenclature revision happened. So patients who underwent a total thyroidectomy and they were going to be started on levothyroxine, we kept the TSH in the lower half of the normal range, similar to low-risk thyroid cancers. For patients who had lobectomy, we kept the TSH normal, only started levothyroxine if the TSH was above the upper limit of normal. We recommended everyone get an ultrasound and thyroglobulin at 1 year, similar to low-risk cancers. And if there's no evidence of recurrence, we suggested thyroglobulin annually for the first 5 years because we wanted to understand what happens to that after. And ultrasounds every other year, so sort of de-intensifying. Because, you know, we understand that it's an indolent lesion, and we are de-intensifying management by suggesting only lobectomy, no radioactive iodine. At the same time, we don't want to increase the burden on patients by increased surveillance. So our protocol, you know, with maybe a certain level of increased surveillance, was basically to understand the disease course and, you know, make better recommendations for the future.
Excellent. We have a question from Ivan Stojanov. The question is, you said 20% of patients were lost to follow-up. Is it a percentage we are comfortable with? And how does it compare with patients with other low-risk neoplasms, such as follicular variant of PTC with minimal capsular invasion? If we're not comfortable with this percentage, do we need to tweak nomenclature or classification of NIFTP to best communicate or educate our patients? Is there a 20% dropout at a major medical center? It is likely even larger out in the community.
I certainly agree. It is, you know, I see patients diagnosed with NIFTP coming from the community and not having any form of surveillance. And, you know, thankfully, most of them do okay. But this is an area of, you know, how much loss to follow up are we okay with? And, you know, if we're, you know, if someone's diagnosed with NIFTP and they're being told that, you know, you had a benign lesion, this was not a cancer, you have nothing to worry about. I think having a NIFTP at this time is not the same as having follicular adenoma. So I think there's not enough that we know about it. So I agree with the question that, you know, a loss of 20% to follow up is not great. You know, ideally in this stage of NIFTP, these patients should somewhat be followed, you know, once a year, once every other year. Because we do have case reports. You know, there's a case report, and recently at our institution also there was, you know, a patient diagnosed with NIFTP 4 or 5 years later having a bone metastasis, and that makes you question, like, did they even have a NIFTP at the beginning? Well, what was it to start with? Was it a NIFTP or not? And probably wasn't a NIFTP if they had a metastasis.
Of course, yes. So let's just restate. I agree with you, and let's just kind of put it out there that, you know, there are you know, single case reports here and there that cannot that perhaps were called PTs, called NIFTP, but I think it's more reasonable to say they were not originally PTC than to say NIFTP. Sorry, let me just repeat that. It's more reasonable to say they were not originally NIFTP rather than to say NIFTP could occasionally be the result of distant metastasis, etc.
I agree.
Correct.
So those lesions probably were not NIFTP to begin with, but they were called NIFTP and lost to follow-up and then had some bad outcomes. So I think these patients do need to be followed for now.
Perfect. We've hit the end of the hour, but before we leave, Dr. Taneja, I'm going to give you the last word. What is your ideal design of a prospective study to answer the question? How would we, or what would we need to give a final word to say, should we or should we not follow patients with NIFTP?
I think the largest and best predictor would be having a prospective diagnosis. So after 2016 and having a longer term follow-up. So mean follow-up of 5 to 10 years would be excellent. And given that these cases started being diagnosed in 2016, it's a little hard to achieve just yet. So I think there's we at our institution definitely have a plan to keep this cohort of patients and look at them again in 5 years and see if anything changed with that longer follow-up or not. But I think the need of the hour is a longer follow-up, and then that would sort of potentiate more formal guidelines to be made.
Agreed. So I want to thank you both so much for taking time to share this with us this morning. I want to invite the audience to come back, not next week because we have the holiday, but the one after, with an incredible lecture with Dr. Suber Belash, who's going to be honing in on the updates of the Bethesda classification system. So thank you all. Have a safe weekend and hope to see you back soon.